I think everyone needed a minute between that. Total switch in terms of topics. I'm Dr. Reynolds. I run the lupus clinic at the Merrimack Arthritis Center along with my lovely colleagues you get to hear from later. I've been doing these talks for a very long time, so I'm happy to see some familiar faces in the audience. I can't see anyone online, so hopefully there's also familiar faces online, or we'll listen to this later. This is very medical. I tried to pick a middle ground in terms of not too much science, but of course, new treatments are all about science. But because I actually have you in front of me, if things don't make sense, if I'm skipping or missing some information, please just interrupt me. I'm happy to slow down and try and explain things a little bit better. So quick overview of current treatment guidelines. I'm going to put up my favorite slide that I teach to all of the residents. I tell them that's one slide is all that they need to know about lupus. I'm going to talk about some of the newer treatments that are currently being used. They're still new for BC patients because we have such restricted access to them, but we're going to go through some of those treatments. And then I'm going to briefly introduce CAR T-cell therapy, which I think is really, really exciting. I think Dr. Hugh talked about it last year a little bit, and I know Antonio was going to talk about it again, but that's how exciting it is. You need to hear about it many, many times. So this is the one slide that I make the residents go through and look at. There is a lot of information. This is designed for physicians, but even physicians like things in pretty colors and red, white, and blue. So it is a treatment for all of lupus. This is kind of what physicians think about when they see a patient with lupus. It is dividing our lupus up into mild, moderate, and severe, and then targeting our medications for that. But I always start with that far column over there in terms of general measures. And I usually spend as much time on general measures as I do on medications, because those things are really, really, really important as you go through your journey. Things like sun protection. We know that UV light is going to trigger our immune systems and our skin, so protecting yourself from just one of those potential triggers for flares, really, really important every day, all the time, the rest of your life. You won't get skin cancer either, so that's a side benefit. Exercise. We talk about it all the time in every doctor's visit, hopefully. It's really, really helpful for you to be as fit and strong as you can be. We know there's risk for heart disease, so a bunch of the other stuff comes down there, but those kind of activities that you can do for yourself, even if it is, as we said, just 10 minutes of exercise, I'm always telling people that 5 minutes is better than 0 minutes. If you can't do what you think you should be doing, that's okay, do what you can do. And that's better than 0. No smoking, that's a given for everybody. Balanced diet, getting vaccinations. So we know that one of the stresses or triggers for people's lupus to flare is infection. So in our current medical system, one of the really good things you can do to prevent infections is to get vaccinated. And yes, there's lots of noise and grumbling about potentially triggering off disease with the vaccinations themselves, but for the vast majority of people, the illness that you get is a much, much, much stronger trigger for a lupus flare. And so we recommend basically any vaccination you can get. We'll talk a little bit maybe later about vaccinations. Perfect. Normal body weight, blood pressure, glucose, those are all because we know there's an increased risk of heart disease in people with autoimmune disease. So anything you can do. So I have patients ask me all the time, what can they eat? And I'm like, you know what? The research isn't great in terms of what your diet should be for lupus per se. A little bit about healthy fats and omega-3s and things. But the cardiologists are ahead of us, and they're telling you to eat a Mediterranean diet. So I'm like, you know what, just go with that, because the main thing you're going to do is help prevent cardiovascular disease. There's tons of good information about a Mediterranean diet. Underneath that, there's more medications. They're not immunosuppressing, but they're things that lupus patients frequently end up on. So acetylsalicylic acid is aspirin. Lots of patients end up getting recommended for that. If they have something called antiphospholipid antibody syndrome, another big mouthful of things, you can actually end up on stronger blood thinners. They're not actually targeting your immune system, but they're targeting this separate increased risk of blood clots. I think Serena touched a little bit on this. Assess adherence to the treatment. It's really, really, really hard to take medication all the time for the rest of your life. And everyone knows that, and we do studies and we can measure how frequently patients fall off on that. It's really important to be really honest with your doctors if you're not able to take things. And I think one of the things we know is sometimes we're a little bit intimidating, and the nurses in the clinic are a little bit less intimidating, so they're always asking you. And that's just to give us an idea. There's no point in me increasing the amount of treatment you're going to take if you're not taking it. So we need to talk about what you're actually taking and if we can change that, if there's a reason you're not taking it, or if you just really are sick and tired of pills and you need a break and things like that. All right, so I'm gonna use up all my time on one slide if I don't move on. So up at the top is mild, moderate, severe. That's how we think of immune system activation in our flares for our lupus patients. And then we try and target our treatment to be mildly immunosuppressive, moderately immunosuppressive, or more severely immunosuppressive, so that we're not giving really strong immunosuppressive agents to people who don't need it. You can see across the top, the first green line says HCQ, that stands for hydroxychloroquine or Plaquenil, and every lupus patient everywhere should be recommended to be on hydroxychloroquine because it's so good at stabilizing the immune system and helping prevent flares. It's not always strong enough. That's why we have all the rest of this. And there are unfortunately people who can't tolerate it. They have rashes, they're allergic, they develop eye toxicity or something. But so the general guidelines are for all patients unless contraindicated. And then the second line down is that's my most favorite drug. Second line down is my most hated drug, and that's steroids. But sadly, they're also really useful across all of our disease manifestations. So we try to use the smallest amount for the shortest amount of time. So nobody should be left on those as much as we can try and get people off, but they are really, really fast and very, very effective. So we end up using them way more than I really would like to. But sometimes, you know, if you've got one joint swollen, we can put the steroids right in one joint and leave the rest of you alone. If your skin rash is only on your knuckles and your hands, we can use a topical steroid there without having to spread it everywhere else. So that's kind of how we try and get around using as much steroid or as little steroid as possible. The colors of the medications is based on how much science is behind them. So these days, to get a new pill to market, you have to do really, really good science. In the olden days, it wasn't that strong. And so some things in yellow, we use all the time, but nobody's done really, really good science about them. Nobody's probably ever going to because it's really expensive and these medications are generic and there's not enough money in it in the business system. So they're left in yellow, but we use them anyways. So if you have mild disease and we've tried Plaquenil, we've used a bit of steroids, and you're still not getting better, then we're going to move on to methotrexate or azathioprine or mycophenolate, which is what those abbreviations are. And then in the green ones are the newer ones with better science of belimumab and anifrolumab, and they try to make these words as long and confusing as possible, and then they make their brand name sound really easy so you remember it. But as physicians, we try to use the generic words because we don't really care about the company that made it in the first place. So those are all things that you might use second line. They are more strong immunosuppressive, so you don't jump to them right away unless you have to. CNI stands for calcineurin inhibitor. So doctors are really notoriously bad for using abbreviations. And if you said the word CNI to a non-rheumatologist, it probably means 13 other things. But for this, I put it up as it is for physicians. So you guys are getting the raw data. This is exactly what doctors are expected to know. So moderate is actually the same medications, but you just start using the stronger medications first line. You think that this is a more severe flare of the immune system, you want to use those medications up front. And then severe disease, again, you're going to use additional immunosuppression up front, but you're going to use stronger ones right from the get-go. So mycophenolate in that sort of orangey color. For general lupus doesn't have great data. I'll quickly show you the kidney lupus data. It's our #1 drug we use when you have inflammation in the kidneys. Belimumab and anifrolumab, I'm going to talk a little bit more about. Sad that I'm still calling them new. Belimumab's been on the market since 2011, but still not widely used in BC. And then down at the bottom, cyclophosphamide is CYC. We use that still for really severe disease. It is a really potent immunosuppressive agent that has been around for a long time. That's why it's in yellowy orange, but I would think most rheumatologists think of it as a green medication. It works really, really well for our lupus patients. It's just really strongly immunosuppressing, and we try not to use too much of it, especially as the cumulative effects over time are also a bit of a hazard. And then rituximab is down there. We still use it. Some of you might have had it. The science is actually negative. I'm not sure why it got yellow. It should actually kind of be darker and orange. The studies they did were failed. So it isn't actually usually considered standard of care, but because so many of us have been using this medication, because as you can see, there's not a huge number on the list, they consider it to be, you know, kind of experience-wise, it is working, even though the science-wise, it didn't work. Far right column is what we're trying to get to. And this is where the difference comes between patients and physicians. We are really good at measuring immune activity in your blood. We are measuring, you know, swollen joint counts with an ultrasound. We're not very good at measuring how you're feeling. Doesn't have a fatigue scale on this remission criteria. So, you know, even though our target for immune treatment might be remission, I think the importance of communication of how you're feeling is still really, really important. And rheumatologists and lupus specialists really recognize that disconnect that exists for patients, but we also recognize that we don't have a good set of evidence that if we put you on stronger immunosuppression, that fatigue and anxiety is going to get better. So that we feel like we're just exposing you to the side effects of those strong medications without making you better. And what we really need is basic science to try and figure out what's driving those other symptoms and how we can treat them better. So currently in this guideline, our treatment is a clinical SLE score, SLE disease activity index. How's that for an abbreviation? You're supposed to be on hydroxychloroquine. Your steroid dose has to be less than 5 milligrams a day. So that's our general remission target. Most patients were happy if we can get to a low disease activity. So that's just a little smidgen. Maybe you've got a little bit of abnormal blood counts that we can see, but hopefully nothing we can measure. And we can use those medications on an ongoing basis for low disease activity, because lots of patients, as soon as you take them away, disease flares up again. So that's the kidney one. I'm not going to spend as much time. It's way easier as scientists to do a study on kidney lupus, because the outcome criteria are very black and white things we measure. And so the green evidence is way more part of the management. We have lots of different combinations of therapies that we use now. So the difference from even 5 years ago was most people would have just got steroids and mycophenolate, and now we're adding in things for a vast majority of people who get disease in their kidneys. And you can see that the bar is getting higher and higher, and things like rituximab that was negative are going to be less and less frequently used. They're not in the new current guidelines unless you failed everything else. All right, so skipping over that, because I think you guys want to hear about new stuff. So interferon. So when we are now looking at the new medications, the science is more advanced, and we're looking at specific pathways in how we know the immune function or dysfunction happens in people. And so we know that patients with lupus have difficulties with this class of proteins called interferons. And the way I think of interferon is they interfere with the viral replication. So lupus patients have inherently difficulties dealing with viruses more than bacteria, because so many of them have this interferon abnormality. There's different types of interferons. They're usually induced by viruses, but bacteria and other microbial things can do it as well. And then that protein that your immune system starts to make binds to the receptors and kind of gets your army going to fight off whatever intruder is coming in. All great until it's you. Interferon in lupus. So 70 to 90% of lupus patients have an elevated interferon level. Interferon expression also correlates with disease activity. So when we measure that SLE disease activity on cross-sectional studies, that we can see higher levels in people with more active disease. doesn't necessarily change over time as much. It's not super, super clean. And it actually is not something that we do on a day-to-day basis because of that. So if you come to see me in the clinic and your disease is flaring, I can't measure this. But if you go and see one of the basic scientists doing research studies, they will frequently do an interferon signature. I say that today in 2025, I'm not sure that 2026, we might not have a way of doing this because science is going really, really quickly and the accessibility of some of this is trickling down to clinical practice. So you can measure it from peripheral blood, but it's really challenging and not done clinically. So basically, if we just took a panel when you came in and you got your diagnosis, if you have a higher interferon signature or interferon levels, that's going to predict that you have more severe disease, you might need more steroids, you might have less time in remission or low disease activity. So the drug companies read all that science too, and they've created this new treatment called anifrolumab or Saphnelo, and it binds to the interferon receptor one. Drug company, lots of money, really pretty pictures online that you can steal. This is what scientists or what we get when you publish your research. So this is what they call a graphic summary of an article that was studied and published in the New England Journal of Medicine. So this is trying to put in 300 patients worth of data all into one little picture to make it easier for physicians, not really meant for patients, but I actually think that this is better than all the other graphs that I could have put up for you. So there was 362 patients, not a huge number. When you go read cardiology studies, they're in the thousands, but for rheumatology, this is actually a pretty big study. It's hard to recruit patients for studies. And they had to have moderate or severely active lupus, and then they put them into either placebo or drug in addition to their regular medicine. So nobody's allowed to come off the regular stuff. This is an add-on to see if they can make people better. So this was anifrolumab intravenously every 4 weeks. So once a month, they had to go in and get an IV and have their medicine put in, or they actually went in and had an IV and had normal saline put in. They didn't know, the doctors didn't know, and then they measured their outcome after a year. So response at 52 weeks. And what they found, and this was a really good bylaws, is a really complicated measure of lupus activity. It's got 108 different things that we measure about every patient, and we compare this week to that week. And lupus researchers, we can write down the assessments and they don't even trust us to calculate it. It has to go to some central place to do this calculation. But it's a really sensitive way of looking to see who's getting better and who's not. But they wanted a really high bar. They want, if you're going to go on this drug, you want to get a lot better. You don't want to get just a little bit better. Otherwise, it's not really worth it to you for the risks. So they found that 47.8% of patients had a significant improvement in their lupus if they were on the drug. 31% had a significant improvement in their lupus, even with just the normal saline. And that reflects that underground, things are always changing in lupus patients. There's flares that will get better. Sometimes the standard medicines that they continued were just slow to make them better, or there was a trigger that settled things down. So we're not surprised to see that amount of people get better with no medication, but we like to see the difference, and that's why they wrote it down. So based on this and another trial, the government in the US, the FDA, decided this drug works for lupus patients and they approved it. Canada did the same thing. It's Health Canada approved. And then over the last couple of years, it's been rolling out. And this is where you guys have a job to do. Every other province in Canada has access to this drug through their publicly funded medical system, except British Columbia. And we're getting really angry as physicians because there's so many of medications that fall into that category, but this one is only indicated for lupus. So this one really falls down on the lupus patients. We can't access this unless you have the good fortune to have a really good drug coverage plan. So we do have patients in BC on this medication, but way less than we would like to. Anifrolumab is on the scale of rheumatology things, fast. We start to see people getting better within 4 weeks. Cyclophosphamide is 2 months, that really, really strong medication, so it's even faster than that. Because of the way it's interfering with that signal with viruses, there is an increased risk of shingles with this. lupus patients have an increased risk of shingles anyway. If anyone's ever considering going on this type of a medication, they need to have their shingles vaccine. It's bad for viruses like COVID. So they were doing this study pre-COVID, pre-vaccination, and they actually did have 3 deaths pre-vaccination. Once the vaccine came out and they could vaccinate patients, there was nothing else. There was no big warning signal. So just shingles is annoying and can give you long-term pain, but it doesn't usually kill you. But COVID is really, really bad. So again, if you were going to consider this medication, you really have to be vaccinated against COVID. So summarizing all of that, type 1 interferon, and you don't have to remember that, but plays a key role in lupus. Blocking it with anifrolumab is effective at decreasing the disease activity in about half of the patients that take it. So we still don't know which patients those are, and that comes with experience and using it more often. It's generally safe and well tolerated, other than getting those vaccines, you know, didn't irritate your liver, didn't irritate your kidneys, didn't cause other rashes and other things like that. Because it's being rolled out for the last couple of years, there's quite a lot of experience in the US and then accumulating in other provinces here. Even in our limited exposure here, I have had some patients with really, really severe skin involvement from their lupus do shockingly well. They've been on 4 or 5 of those other green and yellow medications that are on my list, nothing working, and then they start this and the skin manifestations really improve. And that's Alberta. We had one of the lupologists from Alberta come out and talk to us, and they same experience. And that's what's easy to find on the internet as well. In the studies, there was a good joint response, not amazing. And because of the way they did the study, they excluded people with, they always exclude people with brain involvement. And part of that is because they're just scared of the patient's not doing well in general, but also it's really hard if somebody's brain isn't working properly for them to be able to understand that they might be getting a placebo and that whether they want to participate in a trial. And they always separate out kidney disease because the criteria for kidney disease are so different. So this drug has only been proven to work for things outside of the kidney and the brain. They are doing a trial for kidney disease, but it's not yet published. We don't know what it's going to show. All right, so that's one pathway that's new that we really hope is coming in BC, but if you guys have got angry and wrote them some letters, that might come sooner. B-cell therapy. So one of the other characters in our immune system that is not working properly in lupus patients is our B cells. And there's many, many types of cells in the immune system. This is one that we have been looking at because B cells are the ones that make your antibodies. Everyone who's been tested for lupus knows that we love measuring your antibodies and what you're making antibodies to. And so we know if we just got rid of the cells that make antibodies, surely we'd make you better. And so rituximab, I mentioned already, they actually had negative trials. So for general lupus, as well as for lupus in the kidneys. But they did those trials once people were already using the medication, and then the trials were negative, and everyone just said they didn't do the science properly and still kept using rituximab. And so there's a large body of evidence that it does work, just not for everybody in the real world. And I think as we get better drugs, we'll use it less because the newer drugs are going to be better targeted for lupus. So belimumab, still on my new list, has been available since 2011. I have a patient who actually lived in Texas when they started doing the clinical trials and was in a phase 2 trial. So I think she's been on it since about 2006. So accumulating a lot of evidence, she still takes it every time and consistently, never comes up. So it's available for general lupus, but FDA said, yeah, we think it works, and they approved it. Health Canada said, yeah, we think it works and we approved it so you can get it. But then they had this financial body that looked at it and said, yeah, we don't think it makes enough difference. And so that probably, frustratingly, was partly the drug companies not making it clear why it was the small difference that you saw was so important. But so consequently, none of the private players in BC really picked it up and started paying, or sorry, in Canada picked it up and paid for it. But they very smartly then went on to look at lupus in the kidneys with belimumab. And this time they did a better job of convincing the payers. So now it is indicated for lupus in the kidneys. even in BC. But in BC, there's this BC renal program, and they're currently kind of sitting on it and trying to decide how to might have it approved. So it was, I think, an original slide, I had it in 2025, and now it's partway through 2025, and I don't know if we're gonna get it in 2025 or maybe 2026. But that's gonna be restricted access, mostly for patients who have kidney disease flares. So we still don't have widespread access for general lupus. This is the pictogram of the kidney response that did qualify for improved access to it. So again, not as nice of a picture, but patients who had lupus in their kidneys, they had to get a biopsy, and that showed a certain amount of inflammation. They had to have enough kidney function that it wasn't just scarring and things like that weren't going to get better. They again got placebo versus belimumab, and they carried their study out for 2 years now, for 104 weeks. So we know with inflammation in the kidneys, sometimes it's relatively slow to see improvement. And so they saw at least a partial response in 43% versus 32% in placebo, and then a complete, really good response in 30% versus 20%. And those numbers are as depressing to us as they are to you, that this isn't 80 or 90% better. But if we're left with 20 and we can get to 30, belimumab is really well tolerated. It is a really safe medication. Just about no one complains about it. And because this is a kidney study, it doesn't include all of the other measures of lupus, which also generally are improving. So in your general assessment of how lupus is getting better, it's better than this. Kidneys are just a little bit tougher to treat. And so we would love to have this, certainly with this, belimumab as being, as you saw on that little chart, right up there in green as a first-line treatment in a lot of parts of the world. All right, I just went to a ad board for the company that makes obinutuzumab, which is yet another B-cell depleting medication. Fortunately for rheumatologists, the cancer doctors are way ahead of us. This is a drug that's already approved for cancer treatment, so it makes it just a little bit easier to get access to, as opposed to, say, anifrolumab, which is only for lupus. And it's a stronger B-cell, it's rituximab, but rituximab plus plus. So it's really gonna deplete your B cells, and it's really gonna deplete them for a long time. And they just published their positive data for kidney lupus. I think I have a picture of it. And because of that, they're now doing studies looking at general lupus, and they're looking at even taking some of the steroids away, because this is such a strong medication, which would be really amazing. I'm sure everyone who's ever taken prednisone said, you don't need prednisone, that would be awesome. So that is coming. This is the picture of it. Again, not nearly as pretty as the one. The New England Journal of Medicine has lots of money, so their pictures are the best. This one is someone else's made. So again, looking at patients from a whole bunch of different countries, they all had to have a kidney biopsy that showed they had enough lupus in their kidneys, but enough kidney function that there was something there to improve. Then they were randomized to placebo or this obinutuzumab, and you can see that complete renal response at 76 weeks was 46% if you got the obinutuzumab versus only 33%. So that's our really best kind of thing that they were looking for. They looked at similar kind of spread between the two. If you also just looked at the patients who could also get their prednisone down below 7.5, and without any, and so each of these are other endpoints. Surprisingly, for how well it gets rid of those B cells and you stop making antibodies, and you can see all of the immune markers getting better, generally well tolerated. There were more infections, as you would expect. You're taking out one of the warriors in your immune system to battle infection, so you get more infections. But the nephrologists at that meeting who use it for other kidney disease are actually really happy that for most patients, it's not a big deal. There might be more infections, but they're not really severe infections. And this drug works really fast. And probably we don't even have to use quite as much of it. So there's much hope that this will get relatively quickly taken up by the kidney specialists because it's already used for other diseases. And so we might start seeing patients with that one. I don't know how I'm doing on time. So then CAR T cell therapy. This is super exciting. I think there's lots of information on the internet that's probably better than me in explaining it, but I really wanted to share how excited we are with this. So again, cancer doctors are ahead of us. CAR T cell therapy is something they're using as standard of care for some lymphomas and leukemias. In the early data that we see, the results for lupus patients are capital VERY, very, very impressive. Cure level impressive, not 30% better, not 20% better, but cure level better. So the first case, I think I have the data up, was in 2021 that was published, and things are moving very quickly along in terms of science. But it's still just at a few cases. If you, each time you go to the literature, you can get a few more, but it's still only a few, maybe 100 patients have been treated, certainly no more than that. So yeah, curative with the need for no ongoing medication treatment. It's actually better tolerated for lupus patients than it is for the cancer patients. So when you read about it, if you're looking at a cancer study, you have to take that with a little bit of caution because the lupus patients actually do better. When they counsel the patients with cancer, they have to really talk about all these side effects. And for the first lupus patients, they would have really talked about all those side effects. But it seems like as we're going through, the lupus patients really don't get those severe side effects. So it's better tolerated for lupus patients. But we're not curing cancer, we're treating you. Cancer has some rogue cells that have gone off, and if you get rid of them, you probably cured it as long as you got rid of all of them. You are you, and you're not curing you. We have reset the immune system by doing this, but we haven't changed you. So the long-term follow-up data is going to be really, really important for this before we see who needs it and increase it massively. So there's many trials going on across different sites. Everyone's excited about the amount of data. It's the US sites, Canadian sites, European sites, other countries are all doing studies on this. And they're looking at different ways of attacking the immune system. So I'm going to talk a little bit about what's already been done. Probably the specifics don't matter that much to you. But for some people who are really basic scientists and really looking at how the immune system works, the specific target is really important and probably more important for lupus patients than for the cancer patients where they can just see though, this is the rogue cell, we can just target that and get rid of it. So what is CAR T cell therapy? So you're genetically modifying a patient's T cells to be the attackers. So instead of giving them a drug, you're making your immune system, which is way better than any drug, be the attacker. So you go in, and I have a little picture of that. They take blood cells out of you, they spin them out, and science gathers all the ones that are T cells, so a specific kind of immune cells. And then they tweak them, genetically modify them so that they're a special army that's going to attack a special marker on other immune cells on the B cells. And it's going to deplete those. And because it's your cells, it's really good at getting everywhere in you. If I give you a medication, it might just stay in your blood. And so the blood immune cells get targeted, but other tissues, the bad players hide. In this one, your army is really good at going everywhere, and so it goes everywhere, and it finds those cells hiding in your spleen and hiding in your other tissues and walled off. And so that's one of the reasons why it's so effective. Currently, the T cells are genetically targeting this molecule that's on B cells called CD19. There's another one called BCMA. You guys don't have to worry about that. There are other targets. We get emails constantly about, do you want to be part of this trial? Do you want to be part of this trial? We're going to target this. We're going to target that. I think there's lots and lots of noise, and it's going to come, we're going to figure out who needs CAR T cell therapy in the first place, and then maybe which target would be better for which patient, but those are slower to come down the pipelines. This I think is easier to see in a picture. So I stole this from a cancer, so that's why it's a child. Currently, this is not being used in children with lupus, but it is used with children with lymphoma and leukemias. So number one, they remove the blood cells from the patient. They take out the T cells from that. Number two, they're gonna go into the lab and they're gonna turn those T cells into a little army to attack the patient's own B cells. That's that sort of in between. Then they're gonna grow them up, so they make even more of them, so they don't have to take them all from you, they can grow them up in the lab, and so then they're gonna give you back in number four, infuse those cells back into the patient. So they're your own cells, but they're kind of tweaked and revved up. And then those cells do the hard work. They're gonna attack, in this case, it says cancer cells, but in lupus patients, it's the autoreactive B cells that it's going to attack and get rid of for you. So in lupus, this is the same kind of picture. That part on the purpley blue color is supposed to show the same, just with a little too much science in it. I apologize, I couldn't find a lupus one that was prettier. And I'm not an artist. So that's the same process that happens. It's exactly the same with lupus patients as it is with the cancer patients, but we're going to be starting to measure things in your immune system. So we are going to look at, in the green at the top, that little arrow over time, you can see that when you get infused, you have a certain number of those T cells, but they actually get really excited and they expand in your body, and you can measure way more of them. And then eventually, once they've gotten rid of their target, they settle down. The yellow number is the B cells. So you can see they're revving up the T cells and getting rid of them, and the B cells just disappear. They're really good at getting rid of them. And then the side benefit, the antibodies that we could measure disappear. The complement that is the resource that your immune system uses up if it's trying to fight itself, suddenly you're not fighting yourself, so it comes back and you still have it in there. Patients with kidney disease, their proteinuria goes to nothing. And then this is your summary, your lupus disease activity goes to nothing. So this was the first letter that they published in August of 2021. It was a 20-year-old woman with really, really severe lupus who had failed everything. So she had it in her kidneys, she had it in her heart, her lungs, her skin, her joints. She had been on hydroxychloroquine, she probably still was, high-dose steroids, cyclophosphamide, mycophenolate, tacrolimus, belimumab, because she's in the States and can get that, rituximab, all ineffective, which I think she was in Germany, published in the US, but she's from Germany. And so they talked to her about this treatment that was available for cancer patients, and then she agreed to be part of it. And essentially that picture before, her disease activity went to zero, her proteinuria went to zero, her complements came back, her antibodies went away. 2021 though, she's still only 5 years out. And so we don't know what's going to happen in 10 or 15 years. This is the next one that I could find in 2022. Now we're up to 5 patients. I think it's important to put it up here because I have people coming in and saying, can I have CAR T-cell therapy? I'm like, 4 of them are women, so way more women have lupus than men. Ages 18 to 24, only really, really young patients because they tend to be, they have less scarring and damage, which are things that accumulate over time that we know with lupus. If you have bad lupus at a young age, you've got all those other years of treatments, and if nothing's working at 18, what else are we going to do? So they're kind of forced into taking something that's a little bit more experimental. Disease duration already of on average 4 years, and very, very active lupus, and all of them have lupus in the kidneys. Previous treatment, so much like the first patient, they've been on everything. They've been on steroids, they've been on platinum, they've been on mycophenolate. All 5 of these ones have been on belimumab. 3 of them had something called cyclosporin, azathioprine less so, and then rituximab only 1. And that kind of reflects what I said before. We're not super convinced rituximab works for everybody. And then they all got exactly the same kind of treatment as that person did, and all did really, really, really well. So deep depletion, they got rid of all of those B cells, and then they start coming back. It's not like we got rid of them forever. We targeted the ones that attack you. The ones that come back are like new baby B cells. They don't know as much as, and so they're not targeting your own system then. But how long they stay that way, it's not totally clear. And they're in remission. Disease activity of 0. They're extending out to 17 months in this one, but in lupus world, that's still really early. I want to know what they're doing at 10 years. Side effects though, really mild, the cytokine release syndrome that we really worry about in cancer patients hasn't been a big deal, but still small numbers of patients. No infections, weird. We've wiped out this B system, doesn't matter apparently. That's where I'm gonna leave it and let Antonio tell you what we're doing with our team. But I'm happy to take questions. Yeah,
It said that typically it's done with chemo beforehand. Can it be done without?
so currently it works better because what you're trying to do is to reset your immune system. So if you can wipe out bad players by using the chemotherapy, you reset from a better place. Some of the trials are looking at different ways of targeting the immune cells and won't require that depletion. But the ones that have been published all did have the depletion ahead of time. All of the cancer patients get depleted for sure.
Yeah.
Yeah.
Yeah, do you have any trials here in BC for
Perfect question. So we're gonna have Dr. Adina talk about it.
I'll wait until the end. I don't know if the chat has questions.
There were some chat words on there, but I don't know if there are questions.
Yeah, we're moderating.
Okay,
Okay.
perfect.
Thank you so much. Yeah,
Thank you very much, really. And we do have some work to do in DC, but it's great and very exciting.